First, we answered the question: do we have to have a new medications for hypertension? And the answer was yes, for many reasons related to the insufficient performance, associated complications, use high dosage of the antihypertensive medications, as well as the difficulties found in the field of antihypertensive devices, as we all know. So these are the four pathways under recent research for the development of novel therapy of hypertension. On top is the renin-angiotensin-aldosterone system. And as you know, we have four classic molecules that can block the system: the ACI, the ARBs, the aliskiren, and mineralocorticoid receptor antagonist. But this system is more complex. We have many other receptor and the molecule. We have the type 2 angiotensin receptor. The ARBs blocks the type 1, which is a bad type of receptor. Type 2 is a good receptor. It induces vasodilation, natriuresis. So it is a good idea to stimulate such a receptor. And we have four molecules that can do this job. And now there is current research on this compound 21 structure. It is given orally, and in animal studies, it showed promising results. And it is now under human research. Another pathway is the angiotensin 2, angiotensin converting enzyme type 2, angiotensin 1,7 pathway that stimulates the MAS receptor. These are components of what is called the tissue RAS system. And this tissue RAS system is very active, and it is completely dissociated from the plasma system. And by targeting this system and the stimulation of the MAS receptor, we'll have vasodilation and natriuresis. So it is a good protective pathway, opposite to the angiotensin 1 receptor. So it is a good step to have agonist or activator for the angiotensin converting enzyme type 2 receptor. And now we have the diminazine. This is an established anti-tripodosomal drug, and it is under research. Another target is the agonist for the MAS receptor. However, the most interesting and extensively studied pathway is the angiotensin 3 molecule. Angiotensin 3 comes from the angiotensin 1 through the action of endopeptidase A. And in the brain, we have a very active renin-angiotensin system. And the key molecule in this system is the angiotensin 3 and not angiotensin 2. And the angiotensin 3 will act on the angiotensin type 1 receptor producing vasoconstriction. So it is thought to have a very important role in the pathogenesis of hypertension. And it is a very logic thinking to stop such molecule by blocking the activity of the APA enzyme. And now we have this molecule called EC33 molecule that prevent the breakdown of angiotensin 2 to angiotensin 3. And this was proved to be very good in animals. The problem is that this molecule is given within the brain. It doesn't cross the blood-brain barrier. So now we had this molecule, which is called 3-pastat, which is 2 EC3 molecule combined with disulfide bond. It is given orally. It crosses the blood-brain barrier, and in the brain, it gives the 2 EC3 molecule by a reductase. And we will have blockage of the angiotensin 3 receptor. It has 3 mechanisms of action: by inhibition of the vasopressin release, and improving in the baroreflex function, and inhibition of the sympathetic activity. A unique feature for this molecule is that it does not decrease the blood pressure among normotensive individuals. And it is not associated with hyperkalemia or increase in the potassium level, known drawback among agents that block the RAS system. And we had the first randomized controlled trial announced in last meeting in the American Heart Association, the FRESH study, that compared this molecule versus placebo among resistant hypertensive individuals. However, unfortunately, it was a negative trial. This drug did not prove to be effective, and the company stopped its investment in this molecule. Another target in the RAS system is the aldosterone. And after the publication of the Pathway 2 trial, now spironolactone is considered the landmark fourth antihypertensive medications in patients with resistant hypertension. However, spironolactone is not specific for mineralocorticoid receptor, and it has many off-target actions and the risk of hyperkalemia. So we had eplerenone. It is a very selective molecule, but it had a low affinity to the MRA receptor. So it is not a good potent antihypertensive medication. Added to this, it has a shorter duration. So it should be given twice daily if we want to have a good antihypertensive action. Then we have a third molecule, the ferrinone. It is a non-steroidal MRA blocker. It has a very good selectivity and a high affinity, and it is available now. And it is recommended to be given in patients with CKD and type 2 diabetes. And also it proved to have a good antihypertensive medications action, but it was not tested in normal individual without CKD or diabetes. Finally, we have this molecule, the isoxarinone. The advantage in this molecule is being long-acting, 20 hours, the half-life, and high selectivity and affinity to the receptor. And it was tested in the ISAX hypertensive trial in Japan, and it was proved to be superior to eplerenone. And now it is approved in Japan as a new antihypertensive medication. Another way to block the aldosterone system is to block the key enzyme in the synthesis of aldosterone within the zona glomerulosa, which is the aldosterone synthase inhibitors. The problem with these molecules to inhibit the aldosterone synthase is that it also inhibits the 11-beta hydroxylase. This hydroxylase is important for the synthesis of cortisol. So you will inhibit aldosterone and also will inhibit the cortisone, and there will be a risk for adrenal insufficiency. Now we have a new molecule, the baxdrostat, which is a highly selective for aldosterone synthase. And recently we have this study that compared baxdrostat versus placebo in patients with resistant hypertension. And it proved to be effective with modest reduction in blood pressure in 2 different doses without important serious side effect. So it is expected to enter into phase 3 trials. Now we have the ARNI and we have the neprilysin inhibitor, sacubitril. So does it have a role in treating hypertension? From the pathophysiological point of view, yes, because it will enhance the production of atrial natriuretic peptide, and this will induce vasodilation and natriuresis. Also, this enzyme will prevent the breakdown of many other vasodilatory molecules, such as adenomyodonin, bradykinin, oxytocin, and substance P. So it is expected to be a good novel antihypertensive medications, especially in patients with source-sensitive hypertension, those with systolic hypertension, and those with nocturnal hypertension. It was tested in 9 randomized controlled trials, ARNI versus ARBs, and in a meta-analysis is proved to be superior to ARBs when we consider the office and when we consider the ambulatory blood pressure monitoring. And there was no serious side effects despite the increased rate of cough because of the increased bradykinin production in those patients taking ARNI. SGLT2 inhibitors. we know it had some modest blood pressure reduction characteristics. But also it is associated with significant reduction in the complication, cardiovascular and renal in patients with diabetes, in patients with heart failure, and in patients with CKD. So it is a logic to add this drug in patients with these compelling indications: hypertension with diabetes, hypertension with CKD, hypertension with heart failure, preserved or reduced, to have this strategic reduction in blood pressure, to have this huge benefit in terms of cardiac and renal protection. Finally, the endothelin receptor antagonist. These agents proved to be effective in pulmonary arterial hypertension and also in systemic arterial hypertension. Endothelin act on two types of receptor, type A and type B, and both induce vasoconstriction. However, it has indirect action through endothelin type P receptor to increase the cyclic GMP and to produce vasodilation in healthy endothelium. In hypertensive individuals without healthy endothelium, we will have only the vasoconstrictive effect. So it is a logic to have antagonist for such a receptor, and now we have the aprocitentan, which is a new dual endothelin receptor antagonist tested in the newly published Precision trial, and it proved to be superior to placebo in reducing the blood pressure, whether it is an office taken or the ambulatory, with a difference versus placebo up to 7 millimeter mercury. So it is a modest reduction, but in patients with resistant hypertension. This was my last slide discussing the new direction in the management of hypertension using novel therapy, but we have a long list that include other molecules. Hope one or more of these molecules will have a role in the coming future. Thank you for your attention.
شكرا دكتور كريم for this excellent presentation. يمكن حضرتك قلت يعني some new drugs which are very interesting. يمكن هي المشكلة حاليا هو بعضهم طبعا under research وبعضهم went some trials. يمكن المشكلة when and how to choose these drugs. دي حاجة. الحاجة الثانية إنه we should wait for guidelines to prescribe them. يعني يمكن لسه قدامنا فترة طويلة، لكن which drug you are going to use لو عيان عنده resistant hypertension. يمكن دي المشكلة اللي مفيش حاجة واضحة يعني حاليا.
بالضبط. هو في الفيلد of hypertension it depends on a large epidemiological studies, and this is difficult to be done for several molecules at the same time. So all we have discussed is related to phase 2 trials, waiting for phase 3, then a large epidemiological studies, then post-marketing trials, because the impact of such medications on a large proportion of population, if it had to have a serious side effect, it will be a large burden.
Dr. Karim, thank you very much for this elegant presentation. I want to ask on endothelin receptor antagonist bosentan, which is used in pulmonary hypertension. It may be used as antihypertensive drug.
Bosentan and others such as macitentan was tested in small trials in patients with arterial hypertension, and in these small trials proved to have reduction in the blood pressure, but with many side effects. Namely fluid retention. Endothelin receptor antagonist as a whole entity is associated with fluid retention and increased risk of heart failure in those patients with risk factor for heart failure. And this is not uncommon among the heart failure, hypertensive population. So this may be a limiting step for the use of bosentan or macitentan. And this new molecule we discussed, the aprocitentan, had also a risk for fluid retention and risk of heart failure, but this was with a large dosage, the 25 milligram dose. So the author of this article recommend to start with the 12.5 milligram dose, then to shift to the 25 milligram dose, the same protocol used for post-intan in pulmonary arterial hypertension, to start with smaller dose than a larger dose.
هي الدوز اللي احنا بنستعملها pulmonary hypertension 62.5 twice لمدة شهر، بعد كده 125.
صح.
Avoided in hypertension, systemic hypertension. It's not.
Thank
Thank
you,
you.
Dr. Karim, for this is my question also.
Not tested specifically in patients with isolated systolic hypertension, but based upon its pathophysiological action and its ability to minimize the stiffness of the arterioles, it is thought to have a predilection among those individuals. And interestingly, the dose of these agents in hypertension is single daily dose, not twice daily dose as in heart failure. The 100, the 200, and the 400 given once daily. Also patients with salt-sensitive hypertension, because it's a natriuretic effect, and in patients with nocturnal hypertension. These three types of hypertensive individuals are thought to gain benefit from ARNI molecules.
دكتور كريم، شكرا جزيلا على المحاضره. انا كان نفس السؤال بتاع الدكتور محمد، يعني من among the list الدراج اللي حضرتك اخترتها، احنا دلوقتي عندنا اثنين، SGLT2 انهبيتور والانترستو او الارني. نفس السؤال، ولكن هل ممكن ابدا بعين SGLT2 انهبيتور؟ نفس السؤال برضه، SGLT2 انهبيتور كانتي هايبرتنسيف دراج، خصوصا انه في الامبريج والترايلز اللي اتعملت على SGLT2 كان الليفل بتاع الريدكشن about 5 to 10%، يعني هي مش رقم كبير. يعني ممكن انا استخدمه في العيان زي ما حضرتك قلت السي كي دي، العيان الهارت فيلير، سواء كان ريديوزد او بريزرفد. فهل انا ممكن ابدا بيه كسبيسيفيك كانتي هايبرتنسيف ايجنت في عيان دايابيتيك مايلد هايبرتنشن؟ حضرتك شايف ان ده ممكن الايرا تتجه لكده؟
The new thinking in a hypertension is to consider the risk plus the blood pressure number. And the magnitude of reduction of the blood pressure equal a high benefit in a high risk individuals. If we believe in such equation, so the 7 millimeter reduction offered by the SGLT2 inhibitors equal much in terms of outcome. And based upon the fact that combination therapy is the rule among hypertensive individual, so I think it should be an early drug in those individuals, waiting for a trial to support this hypothesis. So any chance that we can have to add this molecule among diabetic, CKD, heart failure patients, even with mild hypertension, I think it will have advantage.
Thank you very much, Dr. Karim.